Chief of ICU in Security Forces Hospital in Riyadh. We want to welcome Dr. Ahmad.
Thank you very much. Assalamu alaikum. Don't worry, I'll handle it. Yeah, I'll just get it. كيف حالكم جميعا؟ طبعا in the afternoon early, huh? People still postprandial, huh? It will take time for them to wake up. And I suggest billows and bed linen. Good. So first of all, thank you, Ahmad AlJabbary, for organizing such meeting. I think it's very helpful, and you are among the first people who start to make people aware about the phenothromboembolism, which is really very important topic for physicians. In fact, in the state now, they consider any VTE as malpractice. Huh? If one of your patients has developed VTE, it's a malpractice, and we see it every day. And every day I get consulted for a patient with PE or DVT, and whether in the ICU or from pulmonary point of view and so on. So I was asked to give a talk about the VTE prevention in stroke and neurosurgery patient. The discussion will involve the incidence rate of VTE in stroke patient and neurosurgical patient, risk of DVT and PE in stroke and neurosurgical, and common DVT prophylaxis or prevention, and the Joint Commission primarily stroke center DVT prophylaxis metrics. And most probably now people are deviating from the Joint Commission, and they are looking into SIPAHI. Huh? I think the King Fahd Medical City has been already reviewed by SIPAHI, huh? Isn't it? So I'm sure they have, those people who have gone through the accreditation of SIPAHI, they know how much attention was paid to the DVT prophylaxis, isn't it? Good. And then we'll discuss the antithrombotic therapy prevention thrombosis, the 9th edition. This was published in 2012 for the stroke patient. There's 2016 that was published in general for VTE prevention, but the one involving stroke prevention was published in 2012. Now, if you look into VTE in patient, this has been recognized since a long time ago. If you look into the first publication was in 1972. Huh? So Warlow, in fact, in his first publication, 1972, he looked into 30 patients, and at that time, the ultrasound was not as common as now. So they used to diagnose the DVT by using the radio-labeled iodine fibrinogen scan. So he found 60% of those patients has developed DVT, and 13 patients has developed BE. Those are stroke patients. Huh? So from 30 patients, he found that, in fact, the rate for BE and DVT, or the incidence for BE and DVT, was very high among those patients. In 1972, he did the study again. He found DVT also 53 patients, and in fact, PE is 16%. So there's a high rate among those kind of patients. McCarthy in 1977, he did only 17 patients, looking into DVT only, and he found 75%. The reason why I brought this slide, just to tell you how high is the incident rate. So when you see a stroke patient, if you didn't take precautions, stroke means VTE, okay? Keep it in your mind, unless you take precautions. And we'll talk down the road what are the precautions. So generally, any hospitalized patient, they are at risk for DVT if they are age over 65, if they are obese, if they smoke, if they are using birth control or hormone replacement therapy, if they are undergoing orthopedic surgery or even arthroscopy, huh? If they are undergoing gynecological laparoscopic surgery, vascular surgery, major neurological surgery, or spine surgery, or if they are dehydrated, because that increases the risk of also venothromboembolism. Now, we differentiate those into high risk and highest risk. Now, what exactly is high risk for DVT among patients admitted into the hospital? Active COPD. So if you have a patient who's having an active COPD, that increases their risk. So pay attention to the DVT prophylaxis for those kind of patients. If a patient is having active heart failure, ambulation out of the room, which is less than 4 times per day. So even if you see your patient ambulating out of the room, don't think that this is enough, unless he goes more than 4 times per day out of the room. So going just out of bed, walking the corridor is not protective enough, okay? Pregnancy, those who are not in labor, they need to be also on DVT or VTE prophylaxis. Non-weight bearing on admission. So if a patient is not able to bear weight on admission, then most probably he's at risk. Bed rest order, and this is what sometimes we do it for the patient. We think, and how many times you write bed rest? Total bed rest, you write it, and you write it because you think that if the patient is mobilizing, most probably this will put him some risk of falls, blah, blah, all of these things. But if you forget about the VTE prophylaxis, then it's just you are telling him, please get VTE, okay? So if you write an order for bed rest, please take into consideration that this patient needs to be on VTE prophylaxis. Now, what is the highest risk? If a patient has previous DVT. So if a patient has developed previous DVT, then most probably he has a higher risk than the others. If a bed rest is more than 72 hours, if non-weight bearing for more than 72 hours, if there's spinal cord injury, if sepsis or severe infection, then also that's increased the risk. Readmit within 30 days of major surgery. That's also increased the risk for the patient. Major orthopedic surgery of the lower limbs, and major open neurological, abdominal, or gynecological surgery. Cancer diagnosis, especially adenocarcinoma, in fact, increase the risk very high. And current multiple trauma or hip fracture. So these you need to keep in your mind that those patients are the highest risk. Now, studies have shown that up to 1/3 of patients with moderately severe stroke develop proximal DVT, okay? Most of the time, distal DVT is not as bad as proximal DVT because proximal DVT is very easy to propagate into PE, okay? So that's why we're worried about it. So just imagine that 1/3 of those patients with stroke, if you go to the stroke unit and you scan them, I can bet you there's one, especially if they are not started on DVT prophylaxis, I can bet you that at least 1/3 of them you'll find proximal, not only just distal, proximal DVT. Now, looking into the venous thromboembolism risk in ischemic stroke patients receiving extended duration enoxaparin prophylaxis. So this is from the EXCLAIM study, if you have heard of EXCLAIM study. So now, if you look into it, they looked into 166 patients randomized into extended duration enoxaparin in comparison to 150 patients on placebo. They looked into VTE in general or at all, and they found that 2.4% has developed despite they are on extended duration enoxaparin. So don't think that I'm giving the enoxaparin and still those patients will not develop DVT. They could develop it. And you can see that 4 out of the 166 has developed VTE. And among the placebo, 12 patients, which is 8%, okay, has developed the VTE. Fatal PE, good that none of the patient who has been on extended duration enoxaparin has developed it, but 1 on the placebo has developed fatal PE. DVT in general, symptomatic or asymptomatic, you can see symptomatic was none, but 2 has developed symptomatic DVT, and asymptomatic there were 4, while on placebo there were 9. So we are 100% sure that the using of extended duration enoxaparin will reduce the incident, okay, will reduce the incident of it. But if you look into the B value, the only significant was the DVT and VTE in general. So those things, whether it's symptomatic or asymptomatic, most probably if we increase the number of the patient, the N value, most probably that will show some sort of significant. But I don't think it need to be, as long as we understand that even if we put our patient on enoxaparin, an extended duration of enoxaparin, they are still at risk, okay? And you can look into mortality. 30-day mortality, 5 versus 8, 90-day, 8 versus 11, 180-day was 10 versus 12, but none of those was statistically significant. And same thing for the bleeding. We totally understand that bleeding risk will increase with using the low molecular weight heparin. Any question you can ask? Okay. So how can we prevent DVT? in our patient? Movement, okay? Let them mobilize early as possible. Once you think they are safe to start mobilizing, don't delay it, okay? Sequential compression device, think about it. When you cannot start the DVT or PE, which means VTE prophylaxis, think about sequential compression device. They still protect. There is some element of protection using the sequential compression device. Think about the pharmacological treatment, okay, by using the anticoagulation. And if you cannot consider the TID stocking, consider aspirin also. All of these measures can help in prevention of DVT. Now, the Joint Commission DVT prophylaxis, they look into ischemic or hemorrhagic stroke. They look into, they excluded elective carotid endarterectomy, the patient, and they consider patient non-ambulatory at the end of hospital day number 2. So by the end of day number 2, if the patient is not mobilizing, then most probably this patient is non-ambulatory, and this carries the risk, or higher risk for VTE. Look at the activity documented. Is the patient walking the halls or not, okay? If DVT prophylaxis is indicated, it must be documented by the end of hospital day 2. And I think Shibahi have looked into that. And always they say, by the end of day number 2, hospitalization day number 2, all patients should be on VTE prophylaxis or at least addressed, okay? And as I said, day of admission is considered day 1, because this is tricky. This is the antithrombotic and and thrombolytic therapy for patients with a stroke, ischemic stroke. Now, if you look into those guidelines, what they say in patient with acute ischemic stroke or transient ischemic attack, we recommend early, and when we say early, within 48 hours, aspirin therapy at dose of 160 at least to 325 milligram over no aspirin. They found that, and this is grade 1A, okay? They found that those patients with stroke, most of the time people are worried about the hemorrhagic transformation, especially if the stroke is massive. And if you look into the guidelines, say clearly that aspirin has some rule of protection. So you should consider your patient within 48 hours. If you cannot anticoagulate, you can consider aspirin. And they say in patient with acute ischemic stroke or TIA, we recommend early, within 48 hours, aspirin therapy with an initial dose of 160 to 325 over the therapeutic voluntary anticoagulation because of the same thing, okay? So aspirin in the first 2 days, what we shall do with patient with ischemic stroke, we should consider aspirin over the anticoagulation. In patient with acute ischemic stroke and restricted mobility, we suggest prophylactic dose subcutaneous heparin, unfractionated heparin, or low molecular weight heparin, or intermittent pneumatic compression devices over no prophylaxis. So all your patients with acute ischemic stroke should be on some sort of VTE prophylaxis, including unfractionated heparin or low molecular weight heparin or intermittent pneumatic compression device. In patients with acute ischemic stroke and restricted mobility, we suggest prophylactic dose of low molecular weight heparin over prophylactic dose of unfractionated heparin. So those who got restricted mobility, okay, they have found, based on study, that the low molecular weight heparin is superior to unfractionated heparin, okay? Now, VTE provision in patient with ischemic stroke. In patient with acute stroke and restricted mobility, as we said, we suggested against elastic compression device or stocking. So if your patient is acute stroke and he has restricted mobility, what do you think about TID stocking in particular? So based on the guidelines, they say they were against the TID stocking. Does anybody of you know or think why? Okay, so there are many limitations of the TID stocking. Number one, it can induce sores. Okay, it can dislodge. If anybody has developed a VTE, it can dislodge it. So instead of DVT, it could go into PE and so on. So what they say those patients who has restricted mobility, and in fact, most of those massive stroke at higher risk, they are. And very commonly, I come and see them, and I find that they have started them on TID stocking, which is exactly against what the guidelines say. So I want to bring this to your attention just to make sure everybody is aware. In patient with acute primary intracerebral hemorrhage and restricted mobility, we suggest prophylactic dose of subcutaneous heparin or low molecular weight heparin starting between day 2 and 4. So the optimal time to start anticoagulation for prevention is between day 2 and 4. You can start by day 2 if you think that the patient is not having a very high risk for hemorrhagic transformation. If not, then by day 4, all of your patients should be on VTE prophylaxis, okay? And in the first 2 days, you can use the intermittent pneumatic compression device, but not TID stocking if your patient has limited mobility. In patient with acute primary intracerebral hemorrhage and restricted mobility, we suggest prophylactic dose of low molecular weight heparin over unfractionated heparin. They have found that low molecular weight heparin is superior to the unfractionated heparin, as we said earlier. Patient with primary intracerebral hemorrhage and restricted mobility, we suggest against elastic compression stocking, and this is, we said, same thing for the acute ischemic stroke, same thing for intracerebral hemorrhage. Now, if you look into this, in fact, this is a very busy slide, but it just tells you that even aspirin and Plavix clopidogrel, in fact, are effective in terms of prevention of prophylaxis. Now, what do you think about the efficacy of thromboprophylaxis? If you look here, this study, in fact, have looked into multiple, this is kind of looked into multiple study looking or comparing unfractionated heparin and low molecular weight heparin. If you look here, for example, McCarthy and Turner, he has 305 patients, followed them for 14 days. They were in 5,000 unit sub-Q of TDS, and he found that there were 22% versus 73% of DVT. And if you look into the PE, there were 9.9 versus 46 patient. And the intracerebral hemorrhage was almost not significant at all, 5.6 versus 4.2. So this means that starting at least 5,000 units of sub-Q unfractionated heparin is effective in prevention of complication, including DVT and PE, and very low risk of or increase in the risk of hemorrhage. Pampiano also, he looked into 131 patients. He followed them for 28 days, and same thing, he found almost the same finding, okay? Then IST study, that was huge number of patients, recruited 9,712 patients, and followed them for 14 days. But the regimen he used was a little bit different. They used 5,000 patients, and they used, 5,000 units, okay? And he used 12,500 units. So there were two groups of patients. Some of them, they used 5,000 BID, and the other group, they used 12,500 BID. And what happened? DVT, he didn't look into it, but he looked into PE, and he found the difference 0.7 to 0.9%. So it's not really statistically significant, the difference to give 12,500 unit sub-Q BID of unfractionated heparin to a patient in comparison to 5,000. But what was the risk of hemorrhage? He found 1.2 versus 0.3%. So there were increase in the risk of hemorrhage, and that was statistically significant for them. Low molecular weight heparin, almost the same thing. They recruited many patients. They used anaprod, and they used also deltaparin, and they found that it does prevent DVT, it does prevent BE, and the increment in the risk of intracerebral hemorrhage is almost none, okay? Now, if you look into the lower table, they looked into efficacy of thromboprophylaxis with low molecular weight heparin in comparison to unfractionated heparin or aspirin for the prevention of DVT or PE in patients with acute ischemic stroke. And we can see that there are 6 studies, some of them, which is IST study, also similar to the one here. They looked into enoxaparin, danaproid, and also tinzaparin, unfractionated heparin. And if you look into it, it used to be preventive in terms of prevention the complication, which is DVT or PE, and the risk of hemorrhage was not significant except in 2 studies, and these studies were published by Bath, in fact, and the other study was published by IST, looking into the 12,500, as we said earlier, increased the risk of hemorrhage. And Bath, in fact, he looked into the same thing, tinzaparin between 175 and 100, and 175 has increased the risk. So low molecular weight, in summary, low molecular weight heparin, in fact, is good in terms of prevention, but don't overdo it, okay? And even unfractionated heparin is good, but don't overdo it, At that time, they thought by giving 12,500 will prevent the complication of VTE in a patient with stroke, which did, but increased the risk of hemorrhage. Although it is, minimal, but there is increase in the risk. And 5,000, in fact, in comparison to 12,500, there were no big difference, okay, in terms of the prevention. And the same thing for the low molecular weight heparin. When they increase it from 100 to 175, it increased the risk of hemorrhage. And in fact, there is no increase, or let's make it this way, that there is no benefit in terms of increasing the dose in terms of prevention, because even the smaller dose was enough to prevent the complications. Now, if you look into phenothromboembolism prophylaxis and treatment in patients with acute stroke and traumatic brain injury, okay? So, in fact, there are many studies that have looked into that. There is no guidelines that has been published yet in terms of traumatic brain injury or neurosurgical patient, but this is a kind of proposed guideline at that time, which looked into early mobilization if possible, and this has became like ABC for us. And the other thing also, in case of immobilization, we consider low molecular weight heparin, and intermittent external compression devices also is very important, but we should avoid the TID stocking. And in patient with DVT only, start with low molecular weight heparin or unfractionated heparin for pulmonary embolism prophylaxis. Then we add anticoagulation therapy several weeks after acute stroke or TBI onset. Sometimes, I don't know if there is a neurosurgeon here, but sometimes, we get a conflict, especially like in the neuro ICU, we admit many patients with traumatic brain injury. We want to start the DVT or VTE prophylaxis as early as possible, but sometimes we find complication from the, we find restriction or resistant from the neurosurgeon. They said, no, and they try to delay it as much as possible. And eventually we find if we didn't really use the sequential compression device, then most of those patients, they used to develop at least DVT. Now there's a medical study, I don't know if you have heard of it, but medical study is, in fact, I think in this hospital also, and medical study, they looked into the usage of sequential compression device. The interim analysis, because they are almost they're willing to recruit like 2,000 patients, they have recruited already almost like 1,000, and interim analysis has shown that the sequential compression device is in fact very effective in preventing the DVT and PE. Any question? Thank you. Sure. Question later, any? Question?
Our next speaker is Dr. Osama. He is practicing as a subspecialty consultant in the section of orthopedic surgery. He's also the head section of orthopedic and currently the director of the postgraduate department. Dr. Osama.